I would now like to hand over the stage to Dr. Muralidhar Kanchi to talk to us about echocardiography in ICU. Dr. Muralidhar Kanchi is a HOD of Anesthesia and Critical Care, Director Academic in Narayana Hridayalaya Health City, Bangalore. He has a number of publications to his name, close to 99 national and 25 international. He's also contributed significantly to a number of medical books, close to around 10 chapters in the textbooks. He has received Rukmini Pandit Award for the best research paper from Indian Society of Anesthetists in 1990. And he has been the professor of international health. He's got the certification from University of Minnesota Medical School in 1999. He's a course director for international and national trans-esophageal echocardiography workshop under IACTA, and he's the dean of the Indian College of Anesthesia. Over to you, Dr. Muralidhar. Thank you.
My colleagues and friends, it's a great pleasure to be with you this evening to discuss some of the important aspects of use of echocardiography in ICU. I greatly thank Sunil and Jeff for having covered some of my some of the points which I would like to have touched upon, so I will try to avoid them to avoid repetition. And coming to the heart is an amazing pump. It pumps blood into about 100,000 kilometers of blood every day, and it beats 72 times a minute on an average. And it's vital to see how it goes wrong, especially when you're using a non-invasive technique like echocardiography. If you look at the covers of the textbooks which have been published in the last 5 to 10 years, you see that echocardiography has taken a unique place in the management of patients, not only in the cardiology, but also in emergency medicine, critical care medicine, and cardiac anesthesia. Echocardiography is one of the most powerful diagnostic and monitoring tools available in critical care and cardiac anesthetic, and even general anesthetic procedures. If you look at the recent ACLs guidelines and the definition of myocardial infarction, that is the universal definition of myocardial infarction, it is clear that echocardiography plays an important role in management of these patients. Use of echocardiography in intensive care, that is a textbook description. I will not go into the details, but use of echocardiography is a class 1A indication if the patient is unstable, if the patient is having hypotension and not responding to conventional treatment. You need to use echocardiography to quickly diagnose what is the issue in a given patient. In the forthcoming talk, I'll be referring to transthoracic echocardiography, transesophageal echocardiography, and some common pathologies using simulation. And lastly, I'll just touch upon COVID-19 and echocardiography. First, coming to the TPE, that is the transthoracic echocardiography, we have several protocols in place: FATE, FAST, FIELD, FOCUS, RACE, etc. But the FATE protocol has been proposed, it has been published in the European Journal of Anesthesia in 2004, and it's one of the most widely followed protocols. Here, the transducer is placed in 4 positions, which is shown in the slide here. The position 1 is the subcostal, 2 is the apical, 3 is the parasternal, 4 is the pleural position, and the corresponding images are shown here. The top on the left side represent the subcostal view, which is giving the 4 chambers: the right ventricle, interventricular septum, left ventricle, right atrium, left atrium, and this is the apical 4th chamber. Here you see the right side of the structures on the left side of the image and left side of the structures on the right side of the image. And then we have the parasternal long axis and the short axis, which are very vital in examination of these patients. Regarding the screening of the pleura, Sunil has already communicated to us how to look for the pleural pathology and look for consolidation. These are the B lines, which again Sunil has dealt with in detail, so I will not go into the details of these B lines. What are the factors which limit success of transthoracic echocardiography imaging in ICU? These are some of the factors: severe obesity, chronic obstructive pulmonary disease, presence of surgical dressings. We may not get proper windows, and it may be vital to look at the heart from the behind, that is in the transesophageal location. And passage of the transesophageal probe is relatively straightforward. It goes behind the endotracheal tube in most of the patients without any difficulty if the probe is well lubricated, and it is vital to use the white block, and it should not be forced across if there's a resistance felt. Some of the usual bread and butter views are mentioned in the next 4 or 5 slides. This is the transgastric mid-papillary short axis view, extremely important view to look at the volume status and the regional wall motion abnormalities. This is the 4-chamber view in the mid-esophageal window. Again, very important to look at the mitral and tricuspid valves, and the anterolateral and infroseptal segments of the left ventricle. And you have the 2-chamber view, which is extremely important to look at the left atrial appendage, and the pulmonary vein can be interrogated by using pulse wave Doppler. This anterior wall and the inferior wall of the ventricle, which can be seen for not only for contractility but also for regional wall motion abnormalities. Then if you increase the multiplane angle to about 120 degrees, you get the mid-esophageal LV long axis view, which is again important to have a look at the mitral valve, the aortic valve, root of aorta, the interventricular septum, left ventricle, and the right ventricle, as is shown in this picture. Next picture shown will be that of mid-esophageal ascending aortic short axis view. This is the short axis of the ascending aorta, the pulmonary artery dividing into the right and the left main pulmonary arteries. You can see the floating of the Swan-Ganz catheter in this particular case. Coming to the management perspective, if the patient is in low cardiac output state, the shock can be hypovolemic, distributive, obstructive, or septic. So all these patients would exhibit similar clinical picture in terms of hypotension, cold peripheries, tachycardia, obtunded sensorium, and oliguria or renal dysfunction, oliguria, ranuria. And here, if the cause is not readily obvious, echocardiography comes handy to identify the problem. You can see that the one on the left side is hypovolemic, where the papillary muscles are kissing each other, and the one on the right side indicates impaired contractility, which would need inotropic support or use of mechanical circulatory assist device, depending upon the status and the condition of requiring the care of the patient. Here, it's clear that the right ventricle is enlarged and it is compressing on the left ventricle. This again in transgastric mid-papillary short axis view, where the left ventricle is compressed during systole, which means there's a pressure overload on the right ventricle in a patient with severe pulmonary hypertension. The other condition which we may encounter in critical care is the Tokotsuba cardiomyopathy, which is associated with ballooning of the apex during systole, which is shown in this panel, which is labeled as A2. And this, if you do the coronary angiography is likely to be normal in these patients. Coming to pathological situations, I'll be using the simulated pictures here. A lady who presented with hypotension after myocardial infarction, which is thrombolized outside, and low cardiac output, and you can make out that there is pericardial effusion in this case. And the signs of pericardial effusion and tamponade are very clear. The increased JVP and pulsus paradoxus may be there. And pulsus paradoxus is nothing but exaggeration of the normal, decrease in the systolic arterial blood pressure during inspiratory, inspiration, this blood pressure decrease more than 10 millimeters qualifies itself to be called as paradoxes. Similarly, another patient who presented with systolic murmur about 4 days after myocardial infarction. Systolic murmur in a patient who has sustained acute MI could represent either a ventricular septal rupture, as is shown in this picture, or it could be acute papillary muscle dysfunction or rupture leading to severe mitral regurgitation. The other area where echocardiography comes handy or useful is detection of shunts across the intracardiac septum, where we do the bubble test, where its agitated saline is injected onto the internal jugular vein or the central venous cannula or any vein for that matter. And if the bubbles appear onto the left side, this is the left ventricle, left atrium, interatrial septum. If the bubbles appear on the left atrial side, within first 2-3 cardiac cycles, it indicates that there is a atrial septal defect, which may be atrial septal defect or a forced open patent foramen ovale. If the bubbles appear after 3 to 5 cycles, for example, as is shown in this picture, it indicates the presence of a pulmonary arteriovenous malformation. This is the technique which is used in the intraoperative settings also to detect the presence of any breach in the intracardiac septum. Here, the patient's own blood, 10 ml of blood, is taken in a syringe which is attached to the central venous line through a three-way tap. And without adding any air, you apply 30 centimeters of PEEP on the lungs. And as it is released, we inject the blood which is contained in the syringe, and appearance of the contrast on the left side within first 2 cardiac cycles indicates the presence of the intracardiac septal defect. That, I mean to say, atrial septal defect. You also can make out the presence of thrombi, which can be, in this case, the thrombus is in transit. It's going from the right side to the left side across the presence of atrial septal defect or a patent foramen ovale. The other condition which is very vitally important and critical in patients is the presence of diastolic dysfunction. The patient's systolic function may be normal. Patient may suffer from diastolic dysfunction, especially when patients who have poorly compliant left ventricle, or there is a relaxation abnormality of the left ventricle. This is important because when we wean the patients who are on mechanical ventilators, so one of the reasons why we may not be able to wean the patient from the ventilator is presence of the diastolic dysfunction. The patient's the left atrial pressure increases when the heart is pressed with the work of breathing, and hence they wet the lungs and saturation decreases, and you're not able to extubate the patient. So knowledge about the presence of diastolic dysfunction becomes important in intensive care units, not only in the cardiology outpatient departments, but also in the operating rooms and in the intensive care units. The 4 points which are mentioned for diagnosis of diastolic dysfunction are mentioned here. This is the E by E prime ratio. E is the mitral velocity during diastole, which is derived by the pulse wave Doppler across the mitral valve, and E prime is the tissue Doppler velocity during diastole, early diastole. If the average is more than 14, septal E velocity more than 7, lateral E velocity more or less than 10 centimeters, tricuspid regurgitation velocity greater than 2.8 meters per second, and left atrial volume index more than 34 ml per meter square of body surface area. If there are two or more factors positive in this 4 out of the 4, it qualifies to be labeled as diastolic dysfunction, and it is an important component to monitoring patients in intensive care units. The other factor which can be made out is the intracardiac masses, which may be adding to the problems. These vegetations are hallmark of infective endocarditis. These are discrete mobile lesions which are typically present on the upstream surface of the valves, and The other masses which can be detected is the left atrial thrombus, which is hanging loose, ready to get dislodged and cause embolism. And you have the left atrial myxoma shown on the right side of the slide. So these are some of the intracardiac masses which can be easily delineated in patients who are hemodynamically unstable in the coronary care units and intensive care units, as the case may be. Pericardial chapter, I have already mentioned it. Here you are seeing the heart is swinging in a pool of blood. Coming to valvular heart disease, the presence or absence of valvular heart disease can be easily made out, and the assessment of the prosthetic valves is an important component of monitoring these patients in the both post bypass period as well as the post operative period. You look at the ventricular function, morphology of the valve, and any dysfunction of the valve, and look at the gradients, residual regurgitation, and guide the therapy. The transesophageal echocardiography is the important aspect of monitoring and diagnosing patients with dissection of aorta. You see a still picture on the left side, and the dissected aorta in a cross section on the right side of the image. So when you look at these patients, we look for confirmation of diagnosis, assessment of aortic root. Importantly, look at the degree of aortic regurgitation and patency of the coronary ostia. Look at the global right ventricular and left ventricular function. And at the end of surgery, look at the assessment, look for adequacy of repair. The one important point here is that these are the reverberation artifacts. These artifacts may be present normally. So these are abnormally looking things, but they are normal artifacts. So it should not be confused with the pathological findings. But in this case, there is a true dissection. So there have been cases of the operation being conducted based on the echocardiography findings. So this is a pitfall in the echocardiography. If there's a pit artifact, we must look at multiple images and see that the pathology, looking like pathology, what you see is not actually an artifact, and do not unnecessarily subject the patient to a surgical procedure. Here, this slide shows that the echocardiography is as good as MRI or CT in patients who have aortic dissection. I think this is the last case about the pulmonary embolism, diagnosis of acute pulmonary embolism in intensive care units, or in emergency units and the coronary care units. You can see a direct evidence of clot in the pulmonary arteries if you're lucky, but that is rarely seen. But actually, indirect evidence is more commonly seen: right ventricular dilatation, tricuspid regurgitation, increase the pulmonary artery pressures, inferior vena cava dilatation, which does not collapse during a respiratory cycle, may be seen. And typically, there's a description, what is called as McConnell sign, where there is akinase A of the mid right ventricular segments, but the apical segment is normally contractile or even hypercontractile. This is supposed to be typically seen in patients with acute pulmonary embolism, but there has been controversy about this. We will not go into that. Here you can see the aortic, ascending aortic short axis view with a clot in the right main pulmonary artery. So this is a direct evidence. And what is shown on the right side of the slide is the indirect evidence, where there is right ventricular dilatation and annular dilatation is also present. You can see that right ventricle is bigger than left ventricle, indicating that there is right ventricular dilatation associated with dysfunction. Then the other point which we can see is the IVC collapsibility, which collapsibility is usually looked at in the non-ventilated patients, that is spontaneously breathing patients, and you get the maximum and minimum diameters and calculate the collapsibility. And in patients who are on ventilator, you can look at the distensibility index. Currently, this hemodynamic TE is available, where the TE can be left, the probe can be left into the patient's esophagus for as much as 48 to 72 hours to continuously monitor the heart function. But here the imaging capability is only in one plane. You can look at the transgastric view, you can look at the four chamber view, and you can look at the superior vena cava view. Beyond this, we will not have the multi-plane imaging, and we have several the handheld devices. One on the left side is the one which has been introduced about 10 years ago. Now, currently, we have the artificial intelligence capable device which is being introduced today. And in this video, we see the paracentesis of the pericardial space, where this patient had um, significant pericardial effusion with no IVC collapsibility. So echocardiography can be handy in draining the pericardial effusion. In this case, the needle in the pericardial space can be seen here. You can use a contrast that is saline contrast, which can be injected through the needle to be sure that it is in the pericardial space and not in the cardiac chambers, and then put a sheath and drain the fluid. And just after that, if you're successful, you will see that the heart contract, I mean the what do you call the pleural pericardial effusion is released. Coming to last bit of my time talk is about use of echocardiography in COVID. If you look at this uh, analysis of patients, about over 1,200 patients data published from Paris, about 40% have normal echograms in patients who have COVID, but about 50 to 60% have left ventricular abnormality in about 40% of those who have abnormality, heart abnormality, and about 30% have right ventricular abnormality, and in remaining, you have biventricular dysfunction. And this is the slide showing the indications for echocardiography, which could be elevated BNP, suspected heart failure, right or left, presence of chest pain, and other indications. And what is the impact of management is shown on the right side of the slide. So this is again the predictors of abnormality. The red dots indicate abnormal findings in echocardiography. Blue are normal. You can see that patients who have chest pain, signs of left heart failure, right heart failure, and patients who have elevated BNP, you would find abnormal ECGs in such patients. This is the COVID-19 block in Narayana area, and the echocardiography is being done in the COVID unit using precautions, and this is how the artificial intelligence pathway works to give us the ready-made answers. Even if for the expert is not available, a relative novice can put the probe in the positions indicated with little training. Even the nurses and the physician assistants are able to obtain image and send it for analysis. I mean, send it to the expert who may be not physically present there, or he's in another location, and this can improve or help to help us in overcoming the healthcare professional lack of healthcare professionals at a given point of time. This is the algorithm which we use in our hospital. We look at the lung, A profile, B profile, C profile. I don't think I'll go into that. Sunil has explained it. And this is the auto velocity time integral at the left ventricular outflow tract. VTI is calculated to provide us the cardiac output. If you know the left ventricular outflow tract diameter and the heart rate. Similarly, the artificial intelligence is able to let us know the IVC collapsibility and the uh, um, ejection fraction, etc., as is shown in these pictures. So this is the unit, and this is a sequence of how the AI is planned or done to get us the output. Here only two layers are shown, but there are multiple layers within the machine which will let us know the pathology. And this example of automated construction of the mitral and aortic valves in a 5-chamber view, and the automated border detection analysis is shown here, which can be used in critically ill patients. To conclude, I will just give a brief overview of what we have done. We have looked into the indications, though I didn't go into the total list of the indications. We went on the FATE protocol, then we went into the use of transesophageal echocardiography, then we went into the simulated pathological conditions. Then we touched upon very briefly about use of echocardiography in COVID situations. And there is no doubt that echocardiography is a powerful tool which is going to stay with us for a long time to come. And it's a valuable tool for management of diagnosis and management of patients with critical care problems. And before I actually conclude, I would like to announce that the international TE workshop, which